So I'm going to go ahead and introduce Jack Thompson. Jack is Senior Lecturer Emeritus with University of Washington School of Public Health. He's had a robust career in public health, and I know a number of you already know Jack, but he's held a number of positions in local public health at Seattle King County Health Department. He led a consortium of community health centers. He's been in several faculty positions at University of Washington and also served as the director of the Northwest Center for Public Health Practice. He also calls Montana home, and he's previously lived and worked in our great state. He was also instrumental in supporting us in Montana and advising on a number of our public health system improvement efforts when he was a national consultant to the Robert Wood Johnson Foundation's Turning Point grantees. So some of you, I'm sure, remember him from that work. So I will just welcome Jack, and I think you'll really enjoy his presentation style. He is a man who can throw a lot of info at you in a hurry. And so toward that end, we also will make his slides available, and they have speaker's notes, as well as we are taping this webinar. So Jack, thank you so much for agreeing to do this, and it's great to have you working with Montana again. Thank you.
Sure. Thank you, Jane. And before I say anything else, I will just reiterate what Jane said about my speaking style. I've been told many times it's like information from a fire hose or whatever that phrase is. I will try to speak a pace here without going too fast. But as Jane says, you'll have the slides and the notes. So hopefully that will that'll help. But I'll try to pace myself here. I do have a long history with Montana. Just to say a couple words about that. My father grew up in Butte. My grandmother lived there all her life. My dad went to Montana State University, and just for equal time for the other great institutions. My brother-in-law ran the bus company in Missoula for many years, and my niece was born in Missoula. My wife and I lived in both Butte and Billings in the early 1970s, and it was a real honor to come back and work with Turning Point, and then also with Montana, with Northwest Center for Public Health Practice. So very happy to speak with you today, and anybody here who I've met in the past, good to talk with you again. And for new friends, thanks for joining this. So today what I want to do, and it's just a basic goal for the presentation, is to discuss basics about policy development, a little bit about advocacy, a word that I will try to convince you should embrace and be happy about, and talk about the uses and limitations of evidence-based data in relationship to decision-making, crucial to the role of community health strategists. Three parts to the discussion. First, a discussion of some of the basic components of policy development and advocacy. Second, a brief discussion of recent events in public health that underlie and direct the need for a new focus around public health as community health strategists, the focus of your training. And third, conclude with the discussion about the use of data and measurement. And I focus on measurement for reasons I will make clear when I get to that part toward this end, a key part of your role. So let's begin with a discussion of some of the basic elements of policy development. Here's a definition that came from the 1988 Institute of Medicine report on the future of public health. You probably are familiar with that. It was the document that sort of created the context and the flow for public health for the decades that followed its publication in 1988. So this has got the essentials of it. So here's the definition. The key components of policy development: data, other information, and community values. Very important. We'll come back to all of those. The goals of policy development: to address health problems and to build community capacity, which becomes even more important in your role as community health strategist. And the strategies around that are weighing the costs and benefits of options, choosing a course for policy, and making recommendations of programs and services to carry out the policies. Now that's a lot wrapped up in a definition. So here's one that's a little simpler. Public policy, particularly public policy in public setting, it was governments do or don't do. So that encompasses almost all aspects of your work, and I think it's not an exaggeration to say that's a good way to think about it. So what are the ingredients of public policy? First of all, there's the legislative intent, the foundational law, regulation, administrative code, whatever it is that gives public health departments particularly an authority to engage in the policymaking arena. The first component, science, the data, we'll talk about that. The information that's brought to bear on addressing a particular policy. Second component, the politics, the people, communities, values, all of the things that are not quantifiable but are essential for successful policy. And there's a third element that many of us don't pay enough attention to when working on public policy, and that's chance, chaos, stuff happens. The policies that many of us were working on September 10th, 2001, were probably changed dramatically by the events of 9/11 and everything that followed that. There are many occasions like this where our best laid plans are modified greatly by events beyond our control. A policy leader, a strategist will understand that that's part of the deal and keep that in mind as policy is being developed. Fundamentally, defining the issue, what's the problem? We'll go into this in more detail, but what's the problem? Why are we having this discussion? And for whom is it a problem? Who should be at the table to talk about it? Who's affected by it? Who directs it? Who has interest in it? And with what consequences? But what are the ways we can proceed, and what are the impacts of the different ways to proceed on our constituents, the decision makers, and our community at large? About, boy, it's a long time ago, almost 20 years ago, a colleague and I, Aaron Katz and myself, were involved in a national program taking a look at that time, healthcare marketplaces in different cities around the United States. And our particular role was to look at what drives the policy agenda, how is policy used? And we developed an idea that there are specific identifiable tools of public policy that I think are still apply, and I think all of us need to keep in mind as we embark on thinking about policy. First of all, there's regulation. For many folks in the community, this is what they equate with public health: professional licensing, restaurant inspections, permitting, those things where the public interfaces with the health department at its most fundamental level. Taxation, another example of a public policy role. Taxation, ability to levy sin taxes, property taxes, business tax, income tax to raise revenue for programs, another function of government. And these we might say are coercive tools of public policy. But there are many others. There are budget allocation processes that you probably know all too well. There are two big examples of that. There are public programs that are demonstrations of policy. For example, Medicaid, Medicare, many examples in your health departments of local public programs that represent enactment of policy. There's also purchasing, sometimes underrepresented. A health department purchases goods and services, purchases health insurance for employees, and there are many times they're contracting with community providers to provide the direct services. The health department purchases those services, in effect. And we could say that those are examples of resource allocation for policy implementation. For our discussion today, perhaps the most important role a health department has in public policy is information and leadership. The use of the bully pulpit, the public health as a trusted voice in the community. In terms of the community health strategist discussion, as I say, this might be the most important of all. Having credibility with your constituents and putting yourself in a position to help shape policy with the community. When we were doing our work a long ago in the communities, we also realized that while these are sort of the official tools of public policy, there was another one that came up all the time. It would be, we think this is important, but the mayor doesn't think this is important. Or we'd like to come up with this program, but we can't convince our Board of Health that it's a priority. So another tool of public policy, for better or worse, is doing nothing. Remember Thomas Dye said, well, what governments do or don't do. We need to think about a tool of public policy is doing nothing. It's not acting on a particular issue. As I said earlier, the 1988 Institute of Medicine Future of Public Health identified policy development as one of the 3 core functions of public health, and I'll talk about this more in a bit, along with assessment, policy development, and assurance. And this is a phrase from that report that I particularly like. Used judiciously, as we just do, the knowledge base of public health tempers the excesses of partisan politics and encourages just decisions. And I like this sentence particularly. Technical knowledge will have the best effect, however, when used in the context of a positive appreciation for the democratic political process by professionals who are politically as well as technically astute. I can see a smile on the face of the author of that phrase and an assurance to people thinking about public policy. That information sharing and, dare I say it, advocacy for the public health is okay. You have rules to follow, but the basic notion of, as a strategist, playing a lead in this area is a good one. The development of the 10 essential services of public health in the early 1990s further described the specifics of policy development. And those were to inform, educate, and empower, to mobilize community partnerships, and then to develop policies in that context. So from the notion early on of rethinking the role of public health, the notion of policy development was essential. Let's talk a minute about the policy framework. A traditional way to look at that framework is like this. First of all, identify and define the public health issue. That's the policy issue that's important here, not the solution. There's sometimes a mistake made in trying to define a problem. We're actually defining a solution. So for example, one might say an issue might be a need to address adolescent health. The issue is not, we need more teen health centers. That might be a possible option or a possible solution. But the issue is improving adolescent health. Next, understanding the economic market and the social, historical, and political context. What's at play around this issue in the community? What's the history of the focus on this issue? What are the politics, however defined, big P, small p? Very important to know early on. Third, what are the potential options for public policy action? What could be done by the health department, by the community to address the situation? Next, important to identify and analyze stakeholders' interests, values, positions, and power. Again, who has interest in the issue, who has power over its ability to succeed. This whole idea of stakeholder analysis is probably worth a session on its own, a key area. And then finally, analyzing the strengths and weaknesses of options, including both science and values. Again, the need for some analysis before an action recommendation. Another way to look at this takes the same basic framework, but changes the order a little bit, and I'd like to get us to think about this. So again, the first thing is identification of the issue, and we've talked about the various ways we can get at that. But early on, before you go too much further, identify the stakeholders. And once that's identified with whatever methodology you want to use, basic questions, what are their interests? And in that context, what are the policy options? So after a good stakeholder analysis, understanding the interests of the various stakeholders, what are some policy options that can be put in place to address the issue? What are the pros and cons, like the other one? What's the pros and cons? What is in favor of implementing this policy, cost-wise, viability, all that kind of stuff? What might work against it in terms of community opposition or resource requirements or many factors like that? And then another one that I think is really important is what are the unintended effects, the unintended consequences of a policy? It requires some thought. There may be a consequence of a policy implementation that has nothing to do with the thing itself, but it may affect a key stakeholder who is adversely affected by the decision, and it plays out in a different arena. And so thinking beforehand of what might be some unintended consequences of this particular policy implementation is a really, really important characteristic. So who influences public policy? That's what we've been talking about here. Let's stick the first box. We've got public policy made at all different levels of government, national, state, legislative, executive, including the military, judicial, including the police, and to the extent to which it's in play, international treaties. And I'll say more about that in just a minute. So those are sort of the arenas for policy. But there are many influencers of policy: domestic organizations, community-based organizations, non-governmental organizations, religious organizations, and businesses. In some cases, there are international organizations, institutions, and donors that have to be taken into account. And of course, there's the media, news, entertainment, and social media more and more as a factor influencing public policy. I think even looking at public policy in a state like Montana, this notion of international perspective is important for two reasons. One, you're a border state with Canada, and there are many things that have to be done in that context, not only around preparedness, but also around outbreak investigation. You know this better than I. But also we deal with tribal nations in the state and around, and they are governed by international treaties as sovereign nations. And so it's important to make sure their interests are in hand. So that is kind of a 101 of the aspects of policy development. And I just asked Jane if there's been any questions about any of this, or if I should move on.
I guess I would ask the group. I haven't seen any questions yet, but if anybody has anything that they think needs clarified related to what Jack has presented so far, now would be a great time to bring that forward. And you can type it in the chat box, if you would.
And I'll just wait a minute to see if there is anything.
Yeah, let's just give it a sec.
Mm-hmm.
I like to think of what you just presented. I mean, that is a template that could be used by a leadership team in a health department, in my way of thinking, as a way to, if a policy initiative or change to a policy is being considered, I think
Mm-hmm.
it's a way to kind of work through what might be encountered and proactively think through whether an initiative is really viable to move to kind of the next level and get out and be public with it, or if more thinking needs to happen. I don't know, Jack, I just remember at some point kind of using, I think you may have even had like a worksheet that that folks could use what you just presented in that way.
Yeah, I mean, I think following the format, of particularly the second way of thinking about policy with early stakeholder involvement, is a real key to that. We've also done training in stakeholder analysis, sort of plots the stakeholders with respect to power over the issue and interest in the issue. And that leads to a discussion of strategies for affecting policy. And that is worth a discussion. I've got some information on that I could share.
Great. Okay, I don't see anything popping up yet, so let's keep moving.
Okay, let's move on here then. So here's some considerations. In the last decade, there have been a number of things that have happened that directly impact the conversation we're having today. The basic framework for policy development influenced by what I'd say at least 4 important things that have happened in the last decade. First of all, the introduction, or maybe reintroduction, of the idea of the triple aim by Don Berwick and his associates in the article in Health Affairs in 2008. You see the citation there. What Berwick and his colleagues said is most health reform activities focus on the first 2 of these, trying to improve patient care or improving access to care in some way or another, usually expanding programs, has been done with Medicaid and other possibilities. And the other big thing that's driven a lot of quote unquote reform is to lower the costs of healthcare, and for good reason in the American healthcare system. But we don't talk enough about the third one, and that's really what's fundamental to the role of public health, and that is true reform also improves the health of patient populations and communities. So the triple aim said, if you are really thinking about health reform in the truest sense of the word, you've got to think about the triple aim, which adds improving the health of patient populations to the other 2 important criteria. That concept was very influential very shortly thereafter in the passage of the Patient Protection and Affordable Care Act, Obamacare to some. And it's important to remember, there's a lot of talk about the exchanges and the expansion of Medicaid and all that, but it's important to think about in the passage of the legislation, there were also many aspects that were influenced by the triple aim. The creation of a prevention council, prevention trust fund, other population health initiatives, menu labeling, there were a lot of things like that. Now, the implementation of those aspects of the Affordable Care Act is probably also worth a separate seminar. We weren't as successful in holding to all of that as we might have been. But important to note, at the time of the passage of the ACA in 2010, the public health notion part of the triple aim was at the core. Following that was a further development by a panel at the Institute of Medicine, sort of looking at, so what happens next for public health in this context, and in the important concept of health in all policies. And this is a key phrase from the IOM report, and again, there's a citation down there, and I think you are all probably pretty familiar with this, but the notion of consideration of health in a wide range of public and private sector policymaking leads to improvements in population health and also priority objectives in other sectors, such as job creation and reform. And I think it's important for us to say we could add built environment, parks and recreation, employment options. There are many places where it's very important for public health to have a seat at the table. Doesn't always have to be at the head of the table, but needs to have a seat at the table. And so that was an important concept to look at as public health moved into the 21st century. And finally, the all-important initiative that we're all here and you're here in your year-long program to talk about, the notion of Public Health 3.0, the new move of public health that is a large part the consequence or the key strategy coming out of the other three initiatives. Public health's role not in direct service provision only, not in direct service provision primarily, but in a role as a leader, a convener, and a community health strategist in the community. So the skills, leadership skills, very important for this. And this is the context for our discussion today. Convening coalitions, developing broad partnerships with healthcare and other sectors of focus, having an upstream focus, critically important, and also consideration, and this is in some of the literature around Public Health 3.0, also consideration of the use of real-time and new data in the strategist role. And that's what I'd like to spend the remainder of my time talking about. So again, I'll stop for a minute here and see if there's questions or comments. What do you think, Jane? Move on?
I think so. Go ahead.
Okay. Now, I've chosen to call this complicated discussion we're going to into measurement. And one could say use of data. One could say, information-based decision-making. The measurement concept is really important. When Jane and I were working on the National Public Health Performance Standards long ago, there was a phrase that was tossed around, and not tossed around, it was sort of central to the whole operation, which said, what gets measured gets done. And it was meant to say it was time for public health to think about actual measurements, competencies, and demonstrating what it does as an entity. As I'll suggest in a while, turns out that's also a limiting concept, and part of the challenge we have today is to address that. But if you look at the language of the identified practices and the competencies of Public Health 3.0, this concept drives it. The notion of identify, analyze, and distribute information from new, big, and real-time data sources, the notion of accountability, advocacy for use of data in decision-making that affects the health of a community, and ensuring the use of data sources to determine how emerging health trends affect specific populations. All very, very important concepts and central to the community health strategist role. So, a fundamental thing, why measure? 4 reasons, and probably obvious to all of you, but let's just go through them for some grounding. We want to measure for description. We want a concrete way to talk about programs to funders. When a funder, a board of health, commission, a council, whatever your administrative body is, says, what am I buying? You present me a budget, what am I buying, and how do I know if it's a good investment? What do the dollars pay for? Those are the kind of questions that some kind of quantitative measure can help address. Accountability. to assure your supporters or funders that there will be successful implementation of the program. Following that, of course, resource acquisition and management, a political aspect, making the case for budget, making the case for resources to do the work, and finally, most important of all, quality improvement in outcomes. The most important use of measurement, probably of all, and the most difficult. And all of those reasons for measurement blend in the Public Health 3.0 community role of health departments. So what types of measures are there? There are capacity and input measures, the ability to provide services made possible by maintenance of basic infrastructure, processes and activities, what's done by defined individuals as part of the delivery, output, what's the product associated with it, and what's an outcome, what's the impact. So if we were to take a clinical example, just to make this simple, a capacity or input measure might be the number of exam rooms or the vaccine dosages available in any given period of time. The process or activities measure might be the protocols or procedures for immunizations that you have in place. The output might be how many were provided. And the outcome would be the impact on community health improvement. So all important measures, and important to keep clear what it is that is being measured. The biggest problem many times is outputs are being equated with outcomes, and they're related, and maybe they're the only measure we can actually do, but they're two different things. And so there's attribution, the ability to link a particular outcome to the intervention that you are in place, but there's also contribution, that the outcome of a particular initiative is at least, the particular situation in the community is at least partly addressed by the information, by the services you're providing. So the notion of being able to measure all of this is very important. Next, the audience for your work. As community health strategist, a public health department or district is going to be the one who has the capability with epidemiology and with other community health practice to accumulate a lot of the data, to shape it, to lead discussions about it in various settings. And these considerations are really important as that moves forward. Who's the audience? What data should be reported to them? How should it be formatted? How will your audience receive the information? And does the information address expectations? Who's the audience? You would probably present information differently to your Board of Health than you would to a community meeting. Maybe not, but there are certainly situations that differ. What data should be reported? What's most important for the case that is trying to be made here in terms of the intervention? Formatting, you know, is numbers going to convey it? Is it stories? Is it qualitative information? How will the audience receive the information? And then are expectations met by that? I learned early on that one had to really be careful about this. When I was a young, naive health guy, I made a presentation to a community audience in Central Seattle, and I was talking about information gathering, and I was talking about the policy development function of public health. And I kept talking about the surveillance systems we had in place, and I kept talking about the assessment function. And I was getting very strange looks from the audience. I realized that when I used the word surveillance, they thought I was associating it with police and with investigative activities. And of course I wasn't. And when I used the word assessment, they thought I was talking about taxing, raising their taxes. So I had to quickly change language to make sure the audience knew what I was talking about. And that was a lesson painfully learned, but an important one. Concept of Robinson's work and others around this time, about 2004, 2005, the notion of evidence-based public health became very important, and it was following on the heels of a whole revolution in the notion of evidence-based medicine, of trying to do clinical interventions that work, that have been supported by clinical trials and whatnot. Evidence-based public health had to stretch that a bit, because as this definition says, the notion of evidence-based public health was necessary to integrate science-based interventions, you know, the best science had to offer, with community preferences. That theme we've had throughout this discussion of values, participation, stakeholder analysis, community preference to improve the health of populations. So this balancing act, even when you're talking about an evidence base for the policy development, is really critical to keep in mind. So if we're talking about the public health strategist role, a question would be, who will use the evidence? So if that is one of the roles of the health department, well, of course, public health practitioners with executive, managerial, and program responsibilities. What's the evidence for alternative strategies? Important at this point for practitioners to know population attitudes and beliefs. What are the data on interventions? What's worked well other places? All that is important for the practitioners. Of course, as I keep alluding to throughout this, your policymakers, including boards of health, high-level decision-making on resource allocation, and good politicians want to know the evidence for the effects of the options they're being asked to consider or want to propose. So that's the key audience. We've been talking about the key stakeholders throughout this discussion, and they, of course, are an audience. Public and interest groups. Evidence can modify views or suggest different ranges of action for compromises. There'll be different positions that have to be brokered. The evidence can help make a case, can help lead a discussion, depending on what the particular situation is. And finally, of course, the researchers on population health issues, evaluating the impact of policies, talking about interventions based on both qualitative and quantitative evidence, but another field. And this was also in the same documents about evidence-based medicine, evidence-based public health, and the citation is there. A couple more about the evidence base here. One, key characteristics of evidence-based decision-making. Now, again, I'm focusing on this because it's been the driving force for a lot of initiatives from Robert Wood Johnson. It's been important to be able to say to decision makers that our proposed policy interventions have an evidence base. And it's been important also to think about the limitations of it. So we'll talk about both those things now. First of all, a key characteristic is you use the best possible science for the intervention approach. So the literature, prior studies on how to do it, is part of the evidence. So what does the literature say? And sometimes there's a problem with this because the literature often talks about successful situations when the most, as we all know, sometimes you can learn the most from unsuccessful activities, but that doesn't make it into the literature quite as often. So that's probably also worth another webinar at some point. Second, it's key that problem solving is multidisciplinary. Just as public health is multidisciplinary, so is the problem solving. The different professions and skills of practitioners, community, others, all bring something to the table in looking at the options for problem solving. Diverse experiences, diverse educational background, diverse training, focus, all important in thinking about things. Theory and systematic program planning approaches are used. And once again, this includes different models that look at various kinds of interactions and make a lot of use of qualitative information as well as quantitative. So, but doing somewhat systematically to work through the approaches is very, very important. Evaluation principles are followed that are sound. They must be laid out early on in the program development, and they would include different types of evaluation and, as we said earlier, the importance for both quantitative and qualitative data. They're both important in framing and evaluation, and the methodologies used for picking up on that is very important. And finally, dissemination. The results need to be disseminated to others who need to know. And this means, so others in public health can rely on the findings to enhance their own use of evidence in decision-making, that the methodology for dissemination is very important. So the impact of programs can be shared, tested, validated in other settings. And there are other settings, and there are different ways. Something that works in a large urban areas, like I spent much of my time, are not nearly as successful for a variety of reasons in other settings. So a schematic that looks at this would be something like this, and this isn't as complicated as it looks. Follow the process here a little bit with me, just bear with me a minute here, down the left-hand side. So developing the initial statement, again, all that conversation we had earlier about what's the issue, to whom, what's the environment, the context, all that goes into developing the initial statement. To the extent it's possible, quantify the issue. Then this means you have to have data sources identified, qualitative and quantitative, but data sources that will address the issue. Again, what does the literature say about this? Previous efforts, concurrent efforts elsewhere. And that may lead you to do some refining of the original issue. And that's good at this point, because then the next step is to develop the various program options. And there's ways to do that. And if you haven't already done so, this is the time to get community partners involved in having discussions about what will work in a community setting, what won't work, what's happened elsewhere, where do we go with this whole thing. And that leads to the development of an action plan, evaluation plan, and implementation interventions. And so in the public health community health strategist role, that may be leading a discussion about who is in the best position to carry out the actual action plan, who should be doing the evaluation, what interventions need to be implemented, who should be doing that. But again, a role for public health in leading that discussion. And that leads to an implementation, and this notion of thinking about the evaluation at that time with a model that has been developed early in the process is really, really important. And a couple things can happen at that point. One is there may be, again, time to retool the program options that were developed. The evaluation may see in a trial stage, this isn't working so well. Why not? Well, maybe it's something we can do to modify the intervention itself. So there's a thinking retooling. It's kind of like the quality improvement sequence in this respect. And then we move on to either disseminate the program widely or discontinue the program or policy. So this whole system makes sense, I think works, involves the community at times. But I'd like to close today with having some thoughts about issues that you all would need to face, and I've been trying to think about myself in limitations to this kind of an approach. And there are three major limitations I think we need to talk about a little bit. One, there's the issue of sample size for critical populations. We say what gets measured gets done. That has some limited impacts as well. You know, I mean, if we're looking at rural populations where there aren't a whole lot of people, if we're looking at special subpopulations, American Indian populations, Hispanic populations in small communities, the sample size might be really small, but that doesn't mean we shouldn't make sure we come up with interventions to work on it. It means we need to think differently about how we do this. There's nothing worse that we did in Seattle than look at populations that were critical to our city, including Native Americans, and because there were small numbers, we put them together in categories called other and use wide confidence intervals or ranges for possible effectiveness. It just won't work. It's not going to work at all, and it certainly won't work in rural communities. So there needs to be a whole rethinking of how epidemiology works to take into account developing interventions with very small populations. Second, and I've said this a number of times, there has to be a respect and reliance on qualitative data as well as quantitative. The numbers counts are good, but the numbers lead to widgets, which lead sometimes to interventions that aren't going to really make a difference, particularly in terms of community health. This was understood all the way back in those definitions I shared with you that came from the IOM report in 1988 and continues to be important. This is where we get the issues like trust, inclusion, collective impact, all ways to send a signal to the community that values, stories, experiences are an important part of measurement. And finally, what this leads to is we need to develop metrics for key public health. So SDOH means social determinants of health. Sorry for that acronym. Social determinants of health, measures of community wellness. We all agree that health is more than just not being sick. Health has to do with education, has to do with full employment, has to do with good access to parks and recreation, social services. How do we measure that? And again, this notion that we dealt with historically of what gets measured gets done. In some ways, that now is a limiting concept because what gets measured gets done. What gets measured are quantitative, often clinical measures, and they don't get at the broader pictures. There are ways these days and there are people who are working on developing metrics for social capital, for civic engagement, for thinking about stress reduction, and other measures that are upstream, as we're trying to be with community health strategists, and essential to community health. And there are many researchers and epidemiologists who are trying to look at broader sets of measures that can help change the discussion to focus on community health and wellness. That's so important to what we're doing here. So that is my quick thing here, and I probably did talk too fast and probably included too many concepts. And I will turn it over now for some general discussion. I'd just like to say that what you're involved in is an incredibly exciting adventure and a new way of thinking that really is going to be central to the future of public health. We're in the right arena, talking about the right issues. This notion of community health and wellness is on everybody's minds. It broadens the partners who can be at the table. It keeps the definition of public health that we can work with. So I'm glad to see the field is at this point, and I'm glad I've been around long enough to see it come this far, because I think the next steps are going to be exciting and very, very important for the health of Montanans and everyone in the country. So thank you for letting me go through this, and I'll turn it back to Jane for questions or conversation.
Sure. So we have a fairly small group today. We have about a dozen participants. And so I'm going to go ahead.
Okay.
We have a couple questions, and I'll go ahead and first start by unmuting Matt Kelly. But I'm going to try unmuting everyone and asking that if you're not speaking, you do mute yourself, so that we might have a conversation here. But I would ask if Matt would go ahead and lead off with his question.
And if you could also tell me where you work and what you do, that would be helpful for me too. Just quickly, thank you.
Sure. My name is Matt Kelly. I'm health officer in Gallatin County, Montana, which is Bozeman.
Great.
And,
Yep.
and the surrounding area. I think as we went through this, I think this sort of approach, I think you can go and you can engage the community and look at the evidence base, but so often what happens in the sort of political, cultural environment we're in today is it really only takes one specific group of people to show up at a board meeting to derail it from the conversations that we like, that tend to be more analytical and based on the evidence base, into one that's more ideological. And this is almost an impossible question, but I think it's one that we all deal with. So maybe it's a discussion more than it is a question, is, how do you prepare and deal for that situation where you're going down the road, you're working toward policy, there's a strong evidence base for it, but you run into this sort of just ideological opposition, and it might not even be that they're opposed to that particular idea or proposal, but it's part of something. They perceive it as something that is like that is big government, or whatever the case may be. Where it's almost becomes difficult to operate in that environment sometimes. And I would imagine others probably feel that even more acutely than I do in Bozeman. So
just a couple of thoughts, and I'd love to hear what others think. One is, I think the stakeholder analysis helps identify early on where opposition might be, and thinking through a little bit about how to deal with that before it's fully developed, before there's something before the council. That's one thing. More important, and this is kind of a truism, you all know this, I think the rapport you build with the decision makers apart from a specific issue helps with the issue. That if there's a trust in the department by the policymakers and kind of a knowledge of the community environment, we'll work through it. Sure, they're constituents of the elected officials and they have some sway, but this notion of evidence can be used positively. And I think, also we're sort of in it for the long haul. So there's an education process with those folks who oppose an issue, but oppose it for reasons that can lead to possible dialogue and discussion, versus others who are adamantly opposed to it. It's a tough thing, and I think that's a tough thing I faced when I was in a big city health department, and I think you face it in small. I think the current environment nationally and the lack of substantive dialogue around many issues exacerbates it. So I think it's particularly tough for you guys these days. I'd love to hear what others think about that.
I do go back to Jack, that stakeholder analysis piece, because I think sometimes we shouldn't be as surprised as we are when certain contingents come out of the woodwork. We should know.
Mhm.
And you know, it's usually not, I don't know. So I
I probably should have included this slide. We do an analysis. It's got just a 4x4 table that has interest and power, and there's a category of high power but low interest. They're key people in the community who are influencers but don't have a position on a particular issue. They become very important in early formation of policy because you either want to engage them or frankly, sometimes you want to neutralize them. But knowing that they're there is very important. The high power, high interest, everybody thinks means those are our allies and our supporters. Not always. Those are often the key opponents, and also identifying them early on is really important too. So I do think there's value in a good stakeholder analysis with trusted participants, you know, folks you think have a handle on the people in the community. But it's tough.
Yeah, I mean, I think it's true. I mean, there's an example that we've seen nationally recently where, you know, we have a government report coming out on climate change and the impact of climate change and the importance of that, and it's scientifically based and it's broad based and the stakeholders are engaged. And the moment it comes out, the most powerful person in the country who has the ability to actually impact it says, well, I don't really believe it. And that, I think, happens. You know, that's an example of something that's happening at a national level, but I think sometimes in public health that happens at the local level to a great degree. I'm not trying to be defeatist about it. I just think it's something we have to. It's not even about being surprised by it. It's just how do you deal with it because it's there, and it's not going to be. You're not going to change it, so you got to kind of work around it or through it or with it or something.
The other thing, I don't want to monopolize everything with this, but just one more thought. And that's an example, well, I won't say that. There are economic reasons to pay attention to climate change. And I think reframing the discussion around other values sometimes is useful, if not with the particular leader we talk about, but with other people who are influential, who recognize there are financial impacts to not dealing with climate change. It was very hard for Senator Ted Stevens in Alaska, as conservative as he was, not to acknowledge there was climate change because the native villages on the coasts were disappearing as the waters rose because the waters were warming. And he had to reframe his own discussion, as conservative as he was, because there was economic impact to not dealing with the problem. So sometimes reframing the issue in other ways than it's originally presented can have some impact. I don't know about this case, unfortunately.
Yeah, that's a good point.
I don't know. These are pretty challenging times. I just have to say.
Mm-hmm.
We
Mm-hmm.
also had a question from Richland County. Richland County, do you want to jump in? I don't know who else on. I know Kathy Helmuth. I don't know who else is there. Maybe Judy.
This is Judy. Hi. We have 3 AmeriCorps members. We have our hub, 2 hub, chronic disease hub folks, family planning, WIC, injury prevention, and DUI task force.
Wow, you got quite a group there.
Yeah.
Is this my friend Judy, who I used to work with?
Yes, it is, Jack.
Nice to hear your voice.
I know. It was great to see your name on the email that you were doing this. I was so excited and told everyone they needed to be here. You're so knowledgeable. We appreciate it. I guess one of the things that we're noticing a lot from our federal grants is the whole idea, especially our Corporation for National Service grants, AmeriCorps, is making sure that we implement evidence-based programming. But there's a lot of the discussion, they evaluate our programs based on this set of questions, but there's always a confusion, and I don't think the people at the federal level understand this either, is the difference between evidence-based and best practice. Is there?
Mm-hmm.
What is that difference?
Mm-hmm. Well, you asked my thought about that?
Yes.
I would say best practices, this is my bias about this, I would say best practices connote a significant subset of evidence-based. Sometimes evidence-based talks about what does not work as well as what does work. It's part of the experience of adapting programs to particular communities. Best practices kind of have a way of shoving all that aside and just looking at success stories. And those sometimes aren't as replicable as the total experience. So I think, once again, it's kind of a framing issue of what is a best practice into what evidence are we looking at. Some best practices are constituted around things that I wouldn't even consider to be all the evidence.
Gotcha.
There was an example of this. You know, I did a project for Robert Wood Johnson where we were evaluating the success of an initiative, and it had to do with drug reduction. And because drugs were still in communities, the program was deemed a failure, pretty high measure. But what we found was there were some communities where coalitions worked well together, better than others. And one of the reasons for that was a previous initiative got the community to begin working together. So there was a higher level of trust the second time. And so if part of the evidence for the success of this program meant ability of people to work together, to problem solve, it would have been a better outcome than elimination of the drug menace, you know, or whether a simple-minded thing they were trying to measure. So making a case for using all the evidence, I think, is important.
Okay. So identifying the evidence base within that led to that best practice.
Or even beyond the best practice, what's the evidence that would signal success to you and include measures like increased trust, coalition building, you know, stuff that you're going to need not only to solve a particular problem, but you're going to need to move forward as community health strategists in the future on various initiatives.
Good. Good. Thanks.
Mm-hmm.
And the other thing too, I wondered if you had any ideas. You know, we do our community building process and to update our strategic plan on a regular basis.
Mm-hmm.
And it's huge. It's huge. And we tried to attempt a social health index to measure our success. And so, Mike, what happened was it was really hard to narrow down all this data into a few metrics for our community. So my question's kind of twofold. Have you seen some tool that's helpful to synthesize all this data, number one? And number two, have you seen anything where people have used social health indexes, or is that kind of out of date?
No. The first one's really hard because there's a lot of data. The second one, yes, there are examples of organizations that are using social health indices. And if Jane reminds me, I can send you some examples of it. There's some I know. There's some health centers that are doing that. There's health departments that are trying it out. There's an equity lens that's used in King County for new programs. It's not as onerous as it might sound. They're tested, but they're trying to think about looking at stuff more broadly. I think synthesizing all the available data and all the metrics, again, should be at the end of a process that says what really is going to move the needle, or what really will show that we're successful here, not all the stuff you can possibly accumulate. But there are some examples of social indices that, if Jane helps you remember, I can send you some examples.
Yeah, I'm glad to share things. And Jack, if we could share that stakeholder analysis tool, I think that'd be good.
Yeah, I'll do that. I've got a little 4 or 5 slide way to work it through as a something that could be done in Richland County. You could do it with the staff. It's easy. Yeah, I will do that. I'll send it to you.
Perfect.
Thank you, Judy. I appreciate it. And
Yes.
too. A quick thing that I wanted to throw out, just is there anyone out there who would want to share any of their recent experience with working with some of the vaping and other tobacco product kind of ordinances in their local communities? I know we have Lewis and Clark County. There's been discussion here. We have Angie Allen, I believe, is still on the webinar. I know that she has made an attempt at some of that work. Riverstone, and it's been real mixed, and it's been kind of a rocky road, Jack. And I just wonder if there's anything we could pick your brain about while we have you here on that front.
Sure. So summarize what the question would be. It sounds like there's a lot of different experiences with a similar problem in different settings. Is that what you're saying?
Yeah, I'm just curious if anyone wants to raise anything on that issue.
Yeah, okay, good. Yeah, so please do.
I'd help you out there, Jane, but we're in litigation on it right now, so I can't really talk about it in a public setting.
That's not the preferred route. So.
What's that?
I said, to me, litigation is not the preferred route, but sometimes there you are.
No, I know. Angie, is there anything from your experience that you'd want to share, or Lewis and Clark County? I mean, one thing I will share, Jack, I mean, I think that the tobacco industry took a real lesson from the public health playbook with their community organizing of the vaping industry. And so, you know, again, about reframing a health issue into an economic one, they sort of played that trick the other way this time.
Yeah.
And you know, these are small businesses, and this is going to have an impact on the economy of our community. And so, you know, we can't be telling people where they can and can't use these products. So that's sort of the gist of it. And then in Yellowstone County, and I don't know the status now, but it has called into question some of the powers of boards of health and health officers. And so you see that as a real, you know, kind of could become a potential threat to some of the basic infrastructure of public health.
Right.
So that's kind of what's happening. I don't know if anybody wants to add any other kind of color to it, but any advice you have, or what are you picking up about what's happening across the country in that realm?
Well, I think that, yeah, one thing I'd say is it's pretty predictable that opponents of a lot of things will say it affects business or it affects jobs. I mean, that's a pretty standard response. I think it's worth anticipating that before the fact and just trying to do some analysis of whether that's true or not. It often turns out not to be true at all. I mean, there was the minimum wage was raised in Seattle, and the opponents said, you know, the restaurants are going to go out of business. It just didn't happen, you know, and there was enough analysis done to counter that from restaurateurs. So paying attention to the arguments that you know are likely to be made, and it's almost always jobs and economic issues, and they're not always right. So building that into the initial thinking about the policy development, I guess, to the extent possible, I guess is all I'm suggesting. You're going to get that anyway, but anticipating it sometimes can help with framing of the issues.
Okay, well, we're at about the hour. Anything else? I sure don't want to just cut this short, but if anybody has anything else, please pipe up. And then
I'd also say,
go ahead, Jack.
I'd also say if you guys read the notes and stuff from these slides and they suggest questions, why don't you send them to Jane and she can send them to me, and then we can continue the dialogue electronically or whatever's useful.
That'd be great, Jack. And then I just would say this, I want to say thanks to Jack, and I know that he has an appointment to go to, but I would ask for just 2 more minutes with this group, because I wanted to just share, make an offer for the folks in the Community Health Strategist program. So thanks, Jack.
Okay, thank you.
We'll talk later.
Friends I knew, good to talk to you again, and new friends, thanks. Take care.
Mhm. So for those of you in the Community Health Strategist program, I know there have been some challenges with the groups finding technology to have their meetings, et cetera. And I just wanted to let you know that I have this Zoom technology, and I can set up webinars for you to talk to one another, or Zoom calls, or whatever you want them to be, where you can do more than we did on this, where you can see each other and you can all talk and chat and whatever else you want to do. So I wanted to just say that, and I will put it in an email as well. Also wanted to just thank all of you for joining today and participating. So thanks very much.
Thank you for facilitating and reminding us.
Yeah.
This was great, Jane.
Thanks, Judy. Congratulations.
Yeah.
Judy. Richland County
Oh,
is accredited. Yay.
Oh, wow.
finally.
Congratulations.
Thank you, I guess, right? What was I gonna, oh, this could almost be a series, you know?
Yeah, well, we are doing a series with the Community Health Strategist piece. And the next one is because policy ranked as a very high area of interest for the folks in that cohort that are in the program. The next one we're going to do is going to be on how to use the state. This is a very practical thing. How to use the state laws system to track legislation and understand what's happening over there. And then a small piece on advocacy. And that's sort of just trying to be responsive to the needs of the moment since the session is starting. But then the next one after that is going to be on collective impact. And we have someone here in Helena who's really quite an expert on collective impact. Her name is Deb Halliday, and she's agreed to provide a webinar on that and be a resource to us. So I have some others in the works that I'm planning as well, and I'll be getting information out to all of you. So thanks.
Yes.
Thanks,
Thank you. Thanks, Jane.